The next two topics, first by me, MIS applications in deformity, and the next MIS applications in degen. I think we want to do this as like a pro and con. No right answers, but I think it'll be very interesting to see what we come up with. All right. So MIS deformity. So what is MIS, right? So when I was training, a lot of these techniques were just coming out. So I think it's a good time to be a spine surgeon. I mean, there's a lot of techniques. A lot of people have preferences, whether you're O-lift, T-lift, A-lift, or do percutaneous screws. Whatever is good in your hands can be very effective. Typically, what you want to be is, as a surgeon, and the way I think of myself is I want to be a thief, right? I want to be as minimal disruption as possible, get in, do what I need to do, rearrange the anatomy, decompress or have to decompress, and get out. Open deformity surgery, and there's a bunch of us in the audience who do this regularly, it's like getting punched in the face sometimes. I mean, these are tough cases. Big surgeries, high complication rates, as Billy and Sig said this morning. These are not the most ideal patients to operate on a daily basis. High blood loss, high infection rates. I think there's really been a change over the last 10 years with some of these newer techniques that can really augment what we do as deformity surgeons to limit some of these complications, have more consistent results, and ultimately have better outcomes. In terms of complications in adult deformity, it's very high. I mean, there was a paper, I think, I forgot where, but after the age of 70, you can have a 70% complication rate, right? Neurologic injury, blood loss, major, minor complications. In this study, they looked at MIS, open surgery, as well as a hybrid, right? Where they did something laterally, anteriorly, and did percutaneous screws. And MIS seems to show a real decrease in terms of complication rates. So revisiting the anterior column. So I think Justin brought up earlier, Lanky, Boachi, who I trained with. For a long time, especially maybe 10, 15 years ago, there was a real push to do everything posteriorly. The focus is on osteotomies, all these posterior techniques, avoid the anterior column, right? A lot of BMP use. But back in the day, there was a lot of big exposures, right? Thoracoabdominal approaches with all these harm cages at every level. I mean, those are morbid surgeries, and then you flip and do the posterior. But MIS techniques, I think, can really change that, whether it be T-lift, A-lift, X-lift. So the prevalence of MIS techniques is rising. So this was last year, and this was a survey of SRS members. 356 surgeons responded, and nearly half of them reported using MIS for treatment of adult spinal deformity. However, only 7.2% of them used MIS most or all the time. So not a lot of them have adopted this full time, but the prevalence is rising. So comparison and complications, it's very useful. You can do these in very large patients. You can, in terms of complication rates, they're very manageable. Radiographically as well, you can get very good outcomes just by focusing on the anterior column. So in terms of which patients are appropriate, so everything we do is patient selection, right? Whether they're obese patients, whether they're old or smokers, you really want to see which patients are amenable to this. In terms of this classification, I think is very helpful. Usually if you have a lower deformity, something less than 25, 30 degrees, minimal listhesis, low lumbar lordosis, pelvic innocence mismatch, and especially a flexible deformity, I think MIS all day long. If you have a very large fixed curvature, which they class here is class 3, then I think the open vertebral column resections, osteotomies, those are the techniques that I think will be the best. So if you look at this MESDEF class 2 or class 1, pretty minimal deformity, but deformity nonetheless. A lot of the previous presenters have shown cases where you can do a lot of good with this in terms of laterals, percutaneous screws, and get excellent correction both in the coronal and sagittal plane. In terms of something like this, I think MIS techniques are still not appropriate, and you have to do this with a classic big open surgery. So I think I want to show a couple of cases here to illustrate these points. So this is a patient I did a few years ago where she had, as you can see, a significant lateral listhesis, L2-3, L3-4, foraminal stenosis, central canal is relatively open, leg pain, leg giving out on her, 55-year-old nurse. I think a lot of us in this room would consider doing something minimally invasive, right? Anybody who do a T-lift here? Anybody who do an X-lift? Right. And anybody who do a classic posterior operation with screws and a laminectomy decompression? And that's exactly what I did. I mean, I did a 2-level lateral. You can see you get tremendous correction right away. And with percutaneous screws, very, very powerful indirect decompression. Her radicular symptoms are completely gone. The deformity is corrected. And she went, left the hospital day 2 and did very, very well. Now, in terms of lateral-based techniques, again, this curvature is not gigantic, but you can see multi-level degeneration, loss of discite, and foraminal stenosis more than central. This case is similar to some of the ones we've seen before. Again, would somebody do lateral? OLIF. Now, would you OLIF L2 down to S1? Would you do the L5 S1 as well?
No, stopping 5 T-lift.
At T-lift 5-1, right. Anybody would do something else? So again, you can do multi-level lateral-based procedures, and I T-lift the L5S1 and got, I think, relatively good correction. And I didn't really do a direct decompression here. I mean, you can still see the facet joints are relatively intact posteriorly, and just with the lateral cages, the radicular symptoms of polyradiculopathy resolved. So I think anterior-based procedures, especially A-lifts, I think have made a tremendous comeback. You can really restore coronal and sagittal imbalance here. And this deformity, as you can see, is a severe lumbar scoliosis curvature. And again, it's a very flexible curve, right? So if you have a more rigid curvature, then this isn't going to be effective for you. But you can really do a lot of minimizing the curvature just based on anterior techniques. Now, in my hands, this will be a very difficult lateral case. Would any of you guys attempt trying to do this with a lateral? No, it would be very difficult, right? Right. But still, that would be a tricky lateral with a rotation and everything else and with a significant amount of lateral aesthesis. And just with anterior cages alone, and with posterior, I did a hybrid fixation here. You can see you have a tremendous restoration of the deformity with a 3-level A-lift. Now, I think an A-lift procedure is tremendous, but you have to have a very good approach surgeon, right? So we have a very good one at Georgetown that Bobby and I use. And the first thing they want to do when they get in the room is they want to extend the patient, right? And just like when you break the table in a lateral-based procedure, I try to avoid doing that because you can hit many levels with a smaller incision if you do not put the patient in lateral lordosis. So you can do a 3-level A-lift with a relatively small incision, but timing is of the essence, and you have to work hand in hand with your approach surgeon.
Do you over-distract and undersize the cage?
I try to, yes, right. Yeah, because if you bring it into too much, then you're bringing the other levels away from you, right? And the way I do this too is actually start with the upper level. So I'll have my approach guy show me all 3 levels. He'll put the retractors into L3, L4 in this case. I'll do that level, and I'll move the retractors myself at each level, which I don't find being typically too hard. But yes, you don't want to do the bottom one first and really start to move the patient away from you. Then the upper levels are either impossible or very difficult. And this is another patient, GP, again, relatively young patient, 61 years old, but again, a very flexible, large, severe deformity. And you'll see in a second, he has a very big sagittal malalignment as well. But using multi-level cages, you can get fantastic correction in both planes right away. Now, I think this is beneficial because how would you do this based on an all-posterior approach, right? You're maybe T-lift at certain levels, but you're doing significant amount of osteotomies with high blood loss and relatively high complication rate.
You're saying that because the air, it's not fused?
Correct, and also when I do a thin segment CAT scan, I mean you can tell with pretty good certainty which ones are fused and which ones are not. And in these patients, I do get, they're pretty rigid, but when you get that cob in there, you release that ALL and kind of work that cob, you can get a tremendous amount of correction right away. So I think in terms of my bias now, where I train doing everything all posteriorly, T-lifts at 5'1", maybe an axial lift, which doesn't really exist anymore, S2I screws, osteomizing multiple levels, taking on the facet joints, high blood loss, maybe 4-rod techniques, you see Lincoln doing kickstands, all this stuff. I mean, it's a lot of morbidity with a lot of BMP use, but I think you can achieve a lot of correction in these flexible deformities, even with large deformities, by splitting those up into an anterior-posterior approach.
Just one other
Yeah.
comment or question.
Sure.
I notice you're fixing the cages with screws at both levels from the front.
Right.
What's your thoughts on, because sometimes you just put one screw, hold the cage in place, and then
Does that affect your
pull back
deformity correction?
from the back.
No, it does not. Yeah, because you're getting a lot of your corrections just by putting the spacers in. Just like this patient here. I mean, you can see after you get your A-lift cages in, I mean, you're getting a lot of correction right away.
If it's rotational,
Mm-hmm.
I think you're right. I prefer to put one. Sometimes I'll put, I'll look at my rotation on my AB X-ray.
Mhm.
If my rotation looks good, I'll put 2 in. But if I'm still mal-rotated before I've done the posterior, I'll just put 1 fin or 1 screw.
Yeah, I mean, that's a good thought. That's a good thought.
Then in the back, then I put my screws in, and I'll just derotate the whole thing, and then put my straight bars in.
Yeah, just to leave one end plate mobile, right? Yeah.
That's like it's not fixed.
Mhm.
An orthogonal AP, and it looks good, then you put the 2 screws in. But if not, then
Yeah. So good. All right. So I think we're relatively back on time. Next presenter is Dr. Jeff Decky to tell me why all this is wrong.